the dilator goes smoothly in by just rotatory movements, and I land on the bone. This can be verified again. I land on the bone and I feel the interlaminar window by dipping in and out of the interlaminar window. This is the only CM exposure that we need. Of 2 or 3 exposures and our work is almost done in every interlaminar surgery. Then the cannula goes over the dilator and we can just palpate again the interlaminar window and the bone over there. And this is the endpoint of our CM work that we need to do. We can just verify the positioning of our scope and you can see the mobility we can have. After this, all work is done by looking through the endoscope and doing all the work through the endoscope. So this is an animation to show you all the basic steps that we go through, and again we'll go with the live videos. Once we land at the junction of laminospinal junction, we put in our endoscope through this channel and we visualize this area. We removed all the soft tissues and we see all these areas, and we need to verify where we are landing. After this, the bony work starts. We need to remove this part of lamina and till we reach the upper attachment of ligamentum flavum. The next step involves removal of ligamentum flavum, which I will show in detail in my other part of the video. This is the axial cut of the same procedure. We remove the lamina part of IAP and decompress the ligamentum flavum by removing it. Once we are done on ipsilateral side, like this, we can tilt our endoscope towards our side and work on the inner surface of the lamina to access the opposite side. We don't need to do this procedure on the opposite side, we just need to tilt it towards ourselves to access the ligamentum flavum and the neural structures on the opposite side. It is a very simple maneuver which I will show you further in videos. So we'll go through this case to understand what we do in our interlaminar surgery. This was a young patient who came to us with 3-level bulging disc. As you can see, he has a congenital canal stenosis, and a small amount of disc bulge has caused him symptoms of neurogenic claudication. So we planned a 3-level decompression for him, L2, 3, 3, 4 and L4, 5, posterior interlaminar decompression. So I'll just show you one level to signify what we do in this surgery. We landed on left side of the patient. This is cranial, that is caudal. We have landed in the interlaminar window and we are just cleaning the soft tissue. What you see here is we are working on the lower part of the upper lamina, and this is the tip of IAP. This is above thing is the junction between spinous process and the lamina, and this moves down into the tip of IAP. And we basically identify the tip of IAP and we start burning around that region. And we move cranially till we reach the attachment of ligamentum flavum, which is the cranial most attachment of the ligamentum flavum. So what you can see is we are working with a burr on the surface of ligamentum flavum and we detach this ligamentum flavum. I'll just move a little bit back. We have reached till the just move back. Sorry. I'll go a little slow here. So once we reach the upper edge of ligamentum flavum, this is the point where the ligamentum flavum stops cranially. We need to detach it. You can see I am detaching the ligamentum flavum here, and then this ligamentum flavum is detached. There is nothing more cranially that can cause stenosis, so you don't need to remove entire lamina over there. So that is a cranial most attachment, and then you can work on the undersurface of the lamina. This is the opposite side lamina that I am working on. This is the midline, and I am detaching the ligamentum flavum on the opposite side, and I am working underneath the lamina as I had shown in the animation previously. So we just detach the ligamentum flavum and work on the undersurface of the opposite side of the lamina, and then once that work is done, we just remove the remaining ligamentum flavum with keratins. Now some people do it piecemeal like I am doing in this video, and some people remove it in toto. You need to remove the ligamentum flavum till you reach the lower margin and the lower pedicle, and you can see the lateral border of thecal sac and the nerve root going around with it. Now this is the region of lateral recess. You have decompressed our nerve on ipsilateral side, and then you can move to the opposite side to remove ligamentum flavum from the opposite side. This ligamentum flavum can be removed piecemeal or in a single piece, but removing piecemeal is safer. Bit by bit, once you have decompressed on the opposite side, you can see that the lateral recess on the opposite side can be easily seen. And I am working on the opposite side right now, underneath the lamina. And this is basically the endpoint of surgery, where you can see both sides of the nerve root. This is the cranial end, and that is the opposite end. And that is the endpoint that we need to achieve in all of our surgeries, whether it is transforaminal, interlaminar, or UBE. This is what we need to achieve. The lateral part of thecal sac has to be decompressed. So this is the post-operative MRI. You can see we have not touched the disc. We have removed the posterior part of ligamentum flavum, and the lateral recess has been adequately decompressed. And this patient achieves very good result with this surgery. The posterior midline structures have been spared, so there is no chance of instabilities there. In this image, you can see the facet joint have been adequately preserved in all 3 levels. And this is very much possible by interlaminar endoscopy. You can see how much small the neural canal diameter was previously, and post-operatively so much large has been achieved. And so this is what we can achieve with interlaminar endoscopic spine surgery. Advantages being less muscle trauma, faster recovery, reduced hospital stay, minimal blood loss, better visualization, and less risk of